Good afternoon. I'm Dr. Maha Badr, consultant in neuro-ophthalmology. I'm going to talk today about a neuro-ophthalmic emergency. I request the audience to have a piece of paper and pen with them. I'm going to discuss 9 cases. Through my talk, I want you to just write in your note, what do you think we are dealing with and what is the diagnosis, okay? And that's going to help you going slowly with the case, okay? So we will start now the cases. So a neuro-ophthalmic emergency. A neuro-ophthalmic emergency is either life-saving or vision-saving. So this is the most important of us to be able to recognize in timely manner to be able to save life or saving vision. The objective of our discussion is to recognize life-threatening neuro-ophthalmic emergency, to recognize vision-threatening neuro-ophthalmic emergency, to define red flag, and to describe the clinical finding for specific etiology. So this is our objective from our lecture today. So let us go for the first case. So you have a 40 years old healthy female with a new headache and diplopia. She have nausea and vomiting recently, complaining of blurring of vision increase for the last 6 months. This is how she present with, you see, one eyelid dropping in her right eye. So you examined her and you find the vision is 20/20 in both eye, extraocular muscle and lid complete ptosis, loss of elevation, adduction and depression in the right eye, while the left eye is full, pupil in the right eye dilated, not reactive, no afferent pupillary defect, round and regular in the left eye, cranial nerve, both eye within normal, anterior segment within normal limit, and the fundus, there was pallor or of the disc in both eye. So what's your next? What you thinking of? From the clinical history and the clinical finding, what is the other thing coming to your mind? What we are dealing with? So here is you can see here that there is complete ptosis, loss, elevation, adduction, depression, dilated, not reactive pupil, that make you think of third nerve palsy with pupil dilated. Great. But what about the patient complaining of blurring of vision for the last 6 months and the mild temporal disc pallor? So with these things in your mind, does it click? Does it lightening up of other things? So let us summarize. We have here a patient who have headache, nausea, vomiting, blurring of vision in both eye, extraocular muscle, third nerve palsy right eye, dilated pupil right eye, optic nerve but pallor. What's your next step in management? And what is your differential diagnosis? What are you going to do now in your clinic, and what is in your mind? Okay. So you decided to do visual field because patient is complaining of blurring of vision while his vision is 20/20, and you know that Snellen's chart just only checking the fovea. So, and the disc pallor. So here you done a visual field, and what you find here, bitemporal hemianopia. So what's the most likely diagnosis here? So here we have these finding plus the bitemporal hemianopia and optic nerve pallor. What is your next step in management, and what is your differential diagnosis here? So you done imaging, and here we have large pituitary tumor. So the most likely diagnosis here is suprasellar lesion, but what is the worst? The worst is if the patient having pituitary apoplexia. Pituitary apoplexia is an infarction or hemorrhage of pituitary gland in presence of pituitary adenoma. Symptoms and signs is headache are often associated. Vision problem like diplopia due to pressure of oculomotor nerve and ophthalmoplegia. Less severe cases may go to develop various symptoms of hypopituitarism. We might have visual loss, photophobia, and treatment is hormonal therapy, steroid, and surgery to prevent blindness and other neurological complications. So this is a vision and life-saving condition. Here I put the case is not straightforward. You might think of third nerve, you might think of, but just to tell you how you have to keep on thinking in each and every complaint of the patient and each and every symptoms and sign you have. So this was the first case. Is life and vision threatening condition, pituitary apoplexia, present as third nerve palsy. So pituitary apoplexia is life-threatening neuro-ophthalmic emergency, failure to image, immediate urgent neurosurgical intervention, and give endocrine replacement can be fatal. So why is important to know it? Because you are the first line in the emergency room. You are the first person to see the sign and symptoms and able to have the differential diagnosis and relay to your senior what you have. So if you don't see, you cannot diagnose. So remember pituitary apoplexia as a first neuro-ophthalmic emergency we're presenting in this lecture. Let us go to the case 2 and 3. I will present two different presentation and different age and how we are going to deal with it. Case 2 is a 23 years old male, healthy, with a new severe headache and diplopia. As you see here, he presents with left eye, a dropping of the lid. He cannot look up, he cannot look down, and looking to the left, there is full abduction, and looking to the right, there is adduction deficit. What we are dealing with here, we're dealing with third nerve in a young 23 years old complaining of severe headache. Actually, the pupil here was dilated. Don't know whether it's clear, but this is here is the pupil, and here is the pupil is dilated. So we have here a young patient with dilated pupil and complete third nerve palsy with severe headache. So what here vision 2020, extraocular muscle, complete ptosis, loss of elevation, adduction, depression, dilated, not reactive pupil, cranial nerve in both sides within normal, anterior segment normal, fundus is normal. So what's the next? What is your differential diagnosis? Write it in your paper. So here, young, healthy, severe headache and diplopia, extraocular muscle, complete ptosis, loss of elevation, adduction, depression in the left eye, pupil dilated. What is your differential diagnosis and what is your management? Let me go to the case 3. This is a 50 years old female, diabetes. She have diabetes for the last 20 years, non-hypertension and ischemic heart disease. 1 day history of right eye ptosis, exotropia, and hypotropia. Pupil is fixed and dilated in the right eye, as you see here as well. Okay, so the same presentation on the young male. So what's the differential diagnosis and what is your management? So third nerve palsy, dilated pupil, we should be considered posterior communicating aneurysm until proven otherwise. Remember, if you have a patient present with pupil not involved and he just present in the first or second day of the incidents happen, still he might develop an isochoria within the first 5 days of the starting diplopia. This is a very important not to miss aneurysm. Okay, what is the next? What we should do? This is a neuro-ophthalmic emergency, life-saving. What is the next? Is involve the neurology department. We need to do MRI with MRA and sometimes CT angio, because small aneurysm might not be seen with MRA. We should take it very seriously until a pupil involved third nerve palsy is an aneurysm of posterior communicating artery until proven otherwise with CT angio. No, I just want to show you here what is the difference when there is aneurysm, there is posterior communicating artery, and this is the third nerve. You know that a pupillary fiber is present on the periphery of the nerve, and when there is aneurysm start growing, it pressure on the fibers of the third nerve and lead to pupillary dilatation. While vascular disease like a third nerve palsy secondary to vasculitis or vasculopathy, like in diabetes, sometimes it happens. So what happened in the third nerve, that we have the vascular changes from the inside of the nerve, vascular changes, that the periphery of the fibers of the third nerve is not affected, and we might have complete third nerve palsy and pupil is not involved. So this is just showing you the mechanism between both presentation of aneurysm and third nerve palsy secondary to vasculopathy. So what's the management? Urgent, MRI, MRA, and angiography, immediate neurology or neurosurgery referral, Immediate management can save patient curable but life-threatening aneurysm. So life-saving, the rule of pupil. A pupil involved third nerve palsy is aneurysm of the posterior communicating artery until proven otherwise. Normal cranial MRI alone is false sense of security. Ophthalmologists rule to recognize, triage, and refer in timely manner. Let us go to case number 4. So here we have a 30 years lady who is well known as juvenile diabetes, diagnosed by ophthalmology as third nerve palsy, pupil not involved, and there is no history of trauma. And the patient was followed up by the ophthalmologist, no imaging done, and he was reassuring her that might go, she's diabetes, and pupil is not involved, and past the first 1 month, pupil not involved, so he is source of happy that it's not due to aneurysm. And then when he follow her up 3 months later, what did he find? Let us see here that I don't know how to remove. When she looked down here, he finds that the eyelid goes up. The eyelid goes up. So what is this finding? What is this abnormal extraocular motility here? So what's the diagnosis and what is the differential diagnosis here? Although was our diagnosis is third nerve palsy secondary to vasculopathy, but we have to change our diagnosis because what we have here is apparent regeneration. What is apparent regeneration? The most common clinical finding of apparent regeneration are eyelid retraction with adduction, elevation, or depression, and this is called pseudo Van Graaffe sign. Or we might have abnormal extraocular muscle firing, for example, adduction with elevation, or pupillary meiosis with elevation, adduction, or depression. So any abnormal finding that is not understand or abnormal or not usually happen. So think of apparent regeneration. So we have to change. Are we dealing now with aneurysm and tumor go first in the list, and then diabetes will change our diagnosis? So now are we having aneurysm or tumor? So what we should do is an immediate neuroimaging because we are dealing with red flag. Neuroimaging should be done in a patient with with an improving presumed vasculopathy. For example, diabetic third nerve palsy and developing apparent regeneration. In such a case, compression lesion like aneurysm, tumor, often a cavernous sinus should be suspected. So here we change our diagnosis because we noticed that there is apparent regeneration. So this is important. So apparent regeneration is life-saving. Acute painful ophthalmoplegia might be life or vision-threatening condition, proper choice of time of imaging, appropriate consultation with neurological and neurosurgical colleague, early diagnosis and management save life and improve visual prognosis. So let us go to case 5. So I'm giving you a little bit of break between cases. Now, here we have an old man, 70 years old male. He is well known to have hypertension and diabetes, hypertension on treatment for the last 10 years and diabetes for the last 20 years. He gave us a history of a few attacks of visual obscuration before, and suddenly, since yesterday, he have acute, painless loss of vision in his left eye, and the vision is counting finger, and in his left eye, and the right eye was normal 20/20. He have left afferent pupillary defect. In the left eye, the disc was swollen, and as you know here, looking a little milky white, disc swelling, and there was a visual field defect. So what is the differential diagnosis here, and what is your management? This is important here. So, two key questions here. Are we dealing with anterior ischemic optic neuropathy, arthritic or non-arthritic? This is the most important two differential diagnoses here first come to mind. Is it arthritic anterior ischemic optic neuropathy or non-arthritic anterior ischemic optic neuropathy? So you will go back to history. What question you want to ask? If you didn't ask, you want to know if the patient have headache, pain in the temporal or in the neck, pain while showing, if he have any loss of appetite, loss of weight, unusual fatigue, muscle ache or pain, fever, and night sweating. You have to ask the patient. Patient will not volunteer to tell you about these things. Why you are asking these things? Because this is the symptoms of temporal arthritis. What else you will do immediately? You will do ESR and C-reactive protein. Always, whenever I draw blood, I should do CBC and differential. This is whenever you draw blood, do CBC and differential. Sometimes it shows a lot of things. So ESR usually doesn't take, as urgent, doesn't take 1 hour to have the result. So what did you have here? High ESR, and then the result of C-reactive protein came to be high. What you are going to do here? Clinically, this is giant cell arthritis. Patient was having symptoms of temporal arthritis as well. What we will do, start steroid, consult medical, because patient have diabetes and hypertension, so we have to do some investigation to be sure that he does not have TB, X-ray, chest, whatever, but he have to have the medical for controlling the diabetes, because usually with steroid blood pressure will go high up. and arrange for temporal artery bypass. So here, the key point that we are going to start high dose of steroid, maybe IV in the beginning or high oral steroid. How long we are going to use steroid is for a long time if it was proven with temporal artery biopsy that it is temporal arthritis. So arthritic anterior ischemic optic neuropathy is a true neuro-ophthalmic emergency. Why? Why it is a neuro-ophthalmic emergency? Because blindness of the other eye can be prevented. Once one eye is affected, the other eye might be affected within a weeks or a few months. So as I told you, here you have to know how to differentiate between arthritic anterior ischemic optic neuropathy and non-arthritic anterior ischemic optic neuropathy from the age, usually elderly over 60 in arthritic, while the younger age in non-arthritic. Typically sudden and severe, may be progressive. Sudden usually not so severe as arthritic and non-progressive. Ocular pain may be present, rarely present. Amaurosis fugax, usually present in arthritic, while rarely present in non-arthritic. Bilateral involvement common within few days or weeks, while rarely or about 25% within months or years in non-arthritic. Optic disc swollen may be chalky white, while segmental pale or hyperemic. Physiological cup is usually small or large, while usually the other eye might have disc at risk, what we call it, small disc in the other eye. Symptoms of temporal arthritis usually present, usually not present. ESR usually is elevated while normal in non-arthritic ischemic optic neuropathy. The disc later on, we might have marked cupping of the disc in arthritic, while mild, none to mild in non-arthritic. This is differential diagnosis, early and late of arthritic and non-arthritic ischemic optic neuropathy. So giant cell arthritis typically require high doses of steroid with slow tapering over months to year according to the symptom and sign and visual field monitoring to the other eye and monitoring to disc changing in the other eye. Vision saving, arthritic anterior ischemic optic neuropathy is vision saving. Blindness of the other eye can be prevented. If untreated, bilateral involvement is common within 65 to 70% of cases. Once one eye is affected, the second eye can become blind within days or weeks. Case number 6. We have here a 55 years old man complaining of severe left side headache with left face pain. What is your finding here? What you see here in this patient? Look to the patient. What you see here? Look to the pupil. There is a little bit of pupil anisocoria, and it is greater in dark. And what else? There is mild ptosis of the upper lid, as well as upside down ptosis of the lower lid due to paresis of inferior tarsal muscles. what is the important question you want to ask this patient, and what is your differential diagnosis here. The important question here, of course, from the picture, you think you are smart, you think of Horner syndrome. Great. But what is the next? What you want to ask the question? What is the leading question you want to know? You want to know, is this an isolated, if not imaged before? Does he have any other disease? How long has it been? Is it acute, subacute, chronic? Is it painful? If painful, where is the pain? Is it in the head pain, half of the face? Is it in the neck? Is it in the, if there is pain in the shoulder or arm? You have to ask this question. And then you want to look for the pupil to see what is the difference between the daylight or the light and the dark. So what you do here is you be 1 meter away from the patient distance, and slowly you turn off the light, and you start seeing within 5 seconds how is the patient with the small pupil, how is the patient is the difference between the pupil, and usually the difference is more in the dark than in the light. And this is another thing to differentiate between physiological anisocoria and the pupil. But remember that here we have a mild litosis as well. So here is the difference between the dilation lag in 5 seconds between the light and the dark. So what's the differential diagnosis and what is your management here? As you know, here in Horner syndrome, we have the sympathetic is the first order neuron. It passes from the hypothalamus going down to the cervical 7th or thoracic 1. And this is the first order neuron. And then we go to the second order neuron and go to the ganglia, the middle cervical ganglia and the superior cervical ganglia, and this is in the neck. And then we have the third order neuron intracranially go with the external carotid, internal carotid, until it goes to the eye with the carry on with the third nerve to the pupil. So it is a long pathway, and we have to know where we are going to have the problem. So the first order neuron differential diagnosis is we might have stroke, tumor, demyelination. Second order, we might have differential diagnosis, tumor, lung cancer, thyroid disease, in the children, neuroblastoma, lymphoma, metastasis, neck trauma, or previous surgery. Third order is headache syndrome, internal carotid dissection, herpes zoster, complication of otitis media, nasopharyngeal trauma, congenital might be with trauma during delivery. So a lot of differential diagnosis. So what is the next? Usually we hear about the testing of Horner, considered 4% cocaine test. We look for the dilation. If it is positive, normal pupil. If dilation is negative, Horner syndrome, and then hydroxyamphetamine drops. Preganglionic, both pupil will dilated. Postganglionic, normal pupil will dilate. Horner will not dilate. And if these drops are not available, we have aprocoldine may be useful in Horner syndromes. Anyway, now with the imaging, sometimes is we do quick imaging at the same time for head, neck, and chest. And we look for causes in the history, head and arm pain, previous thyroid or neck surgery and neck trauma. We look, examine thyroid enlargement, neck mass, iris heterochromia, neck scar or thyroidectomy before, wasting of ipsilateral hand muscle due to brachial plexus lesion on Pascoe tumor, chest CT, MRI, neck and brain. Usually for me, if there was no previous surgery or trauma or diagnosed before, then I go for imaging immediately for neck, head, and chest. Now, in isolated Horner syndrome, if there is acute neck and face pain, this is a real emergency because we have to rule out carotid dissection, and this is very urgent. Subacute neck in the face, again, localized, rule out carotid dissection. Chronic pain in the shoulder or arm could be preganglionic and imaging to the lung. Okay, so when we do imaging to all of them, and this is the safest, I think, if we don't have the drops. Now here is carotid dissection is a life-saving. History of trauma, neck pain, isolated Horner syndrome, transient visual loss, branch or center retinal artery occlusion, distortion of taste, all these symptoms of carotid dissection. So anisocoria is sometimes is life-saving, which is bad and which is dangerous or benign when we have anisocoria. Small pupil is dangerous. Look for Horner's, dorsal midbrain lesion or tumor. Dangerous big pupil when we have big pupil, third nerve palsy with pupil dilated. So we have to rule out aneurysm. So this is a the rule of life saving dangerous pupil, whether it's small or large. So small, be sure that we are not dealing with Horner's, and a dangerous big pupil if we have third nerve palsy with pupil dilated. So we still have case 7, 8, and 9. Let us go for case 7. Okay, you have a call from emergency department telling you that the physician think that this patient, his patient have papilledema. Okay, you said that you are coming to see the patient immediately, but what is the first question you should ask the physician while you are in the phone? What are you going to ask him? Think. Important question. You will ask the patient from the ER department who are calling you. What is the single question you're going to ask? Anybody know? What is the blood pressure of the patient? Okay, so this is a very important question. Malignant hypertension can cause bilateral papilledema and should have immediate treatment. And usually it's have disc edema, and you might have soft cotton wool spot and splinter hemorrhage scattered in the fundi. So malignant hypertension can be complicated by aortic dissection, coma, pulmonary edema, heart attack, heart failure, stroke, sudden kidney failure. So by immediate your phone question and the thinking of papilledema you are going to see, they might start treating the patient to avoid sudden death, and this is considered is a life saving. Okay, this patient might come to you in the clinic, so it is important to check the blood pressure and look. Sometimes the nurses check the blood pressure, but you have to look to the blood pressure whenever you're dealing with patient with papilledema. So remember, a life-saving condition is malignant hypertension, where you have, of course, to immediate referral to medicine and neurology for immediate slowly lowering the blood pressure to avoid ischemic optic neuropathy as well. Case number 8. Now you have been called or optometrist refer for you a 25 years old female patient referred for you because of abnormal disc. Vision is 20/20 in both eye. What are you seeing? Here you see a bilateral disc edema. Okay. What's the next? You have to look for the history for headache, nausea, diplopia, focal neurological sign and symptoms, full ophthalmic examination, including visual field. Papilledema is a life-saving condition, and there is a lot of differential diagnosis. Are we dealing with pseudotumor cerebri? Are we dealing with cavernous sinus thrombosis? Are we dealing with a tumor? Are we dealing with autoimmune disease? So is differential diagnosis, are we dealing with optic neuritis, ischemic optic neuropathy, compressive optic neuropathy, infiltrative optic neuropathy, pseudotumor cerebri, venous sinus thrombosis? Some of them are vision threatening. Of course, papilledema can be vision threatening if it's not treated. We might have loss of vision, loss of visual field, life-threatening as well. Lot of differential diagnosis. It have to be dealt with the proper diagnosis and as well as referral to neurology for further management. From the optic disc itself, sometimes you might have hint, sometimes you might not have hint of what is the diagnosis, but we can rule out or put a differential diagnosis, and here is different taste of disc edema. From it could be acute, could be chronic, could be atrophic, could be pseudo disc edema. We have to know how to differentiate between pseudo and true disc edema. So the management, evaluation, immediate evaluation, neuroimaging, refer for lumbar puncture. If imaging is negative, neurological, neurosurgical consultation, and assess optic nerve function. And here with neuro-ophthalmology, usually this cases is followed up between both neurology and neuro-ophthalmology for follow-up. What is papilledema improve, not improve, visual field is getting worse, getting better? What is the treatment? Are we going to go for neurosurgical intervention if it is tumor? If it is idiopathic intracranial tension, are we going to go for lumpectomy shunt or optic nerve sheath decompression? So there is a lot of management, but you have to be able to know the differential diagnosis and immediate referral and management. This is important. You might save vision and life. Here we come up to our last case, case number 9. And let us see. Now, we have a patient who complains whether he is young or old. Let us, for example, say a 30 years old male patient came and he said that I have a few attacks of loss of vision and come back. And ophthalmologist done full ophthalmic examination, including visual field, and was all examination normal. This is very important. What is the next? What to do with this patient? Reassure him and tell him that you are okay, nothing is wrong with you, your vision is perfectly normal. Maybe you think that you have loss of vision, you don't believe him or believe him. What's the next? No, we have to believe the patient. So what's the next? What we are going to do? Go to the history and check in the history the main symptom and duration. Is it sudden? Is it less than 30 minutes? More than 30 minutes, the attack of loss of vision? Is it for a few seconds? More than 30 minutes? Less than 30 minutes? What's the age of the patient? Is this loss of vision happen in one eye or in both eyes at the same time? If there is any precipitating factor, is he happen when he bending, standing from lying down to standing up? Is it looking in certain position? Does it happen with exercise, when he do exercise or in hot weather? What is the speed of onset? What is the nature of visual symptoms? Is it he have flashes, zigzags line, like we call it positive phenomena, or negative phenomena, blacking out or blacking out of vision? Is it progression? The speed and nature of recovery, how the recovery happen? Any residual symptoms or return back to normal? If there is headache associated, all this you have to ask in your symptoms. You have to ask. And then you go ask for neurological symptoms. Do you have headache? If you have headache, what's the nature? The time, whether before, during, or after the episodes. If there is any nausea, vomiting, if there is photophobia, if there is transient numbness, weakness, did you collapse, you faint, talking or walking abnormality, did you have any talking, any other neurological symptoms? You have to ask for ophthalmic symptoms like transient diplopia, halo around light, or red painful eye. I assume when you do the full ophthalmic examination, there was no dryness, severe dryness of the eye, for example. So we assume that all ophthalmic examination is normal. You have to ask if an old patient for sign of giant cell arthritis, fever, is he have weight loss, arthalgia, jaw claudication, malaise, difficulty in pain on temporal, we discuss sign and symptom of giant cell arthritis, so you have to ask for it. You have to ask for neck pain, recurrent neck trauma, road car traffic accident, or if he have recent cryopractice manipulation, or he have been in roller coaster rider في ملاهي or something. So all these you have to ask in the history. You have to ask for past medical history carefully. If he was well-known case of migraine before, does he have in childhood recurrent motion sickness? They call it saminoplasm. Is he have stroke before? Diagnosed a stroke? If there is any atherosclerosis risk factor, social history of smoke, family history of migraine, all these you have to dig in his history. Patient will not volunteer to tell you anything about this. All this is helping in your thinking and in your differential diagnosis. What is the next? What is a differential diagnosis? We are looking for vascular risk factor, symptom and sign of giant cell arthritis, a neurological examination like contralateral symptom and sign, cardiovascular examination like carotid or heart, sedimentation rate, ESR, C-reactive protein, like in giant cell arthritis, arthritic ischemic optic neuropathy, blood disease like hypercoagulation, antiphospholipid antibody, autoimmune disease. So this is in differential diagnosis. What we are going to do with the patient, he is in your clinic. We going to rule out, is he a migraine? But you know, migraine is a diagnosis of exclusion. We have to rule out retrochiasmal lesion like tumor, AV malformation, seizure activity, vascular like giant cell arthritis, vertebro-basilar insufficient, especially if the patient have bilateral simultaneous loss of vision. So we will think with vestibulobasilar insufficient, systemic hypercoagulatory disease. So what I'm going to do with him, I'm going to order some laboratory investigation, and this is the list which I usually order: CBC, fasting blood sugar, blood cholesterol, ESR, C-reactive protein, PT, PTT, anti-cardiolipin antibody. This is for hypercoagulation disease, anti-phosphocholine and serine hypercoagulopathy disease, anti-nuclear antibody for SLE, serum protein electrophoresis for hypercoagulation disease, VDR, FTA, ABC for syphilis, protein C and protein S for anti-phospholipid antibody, radiological for carotid ultrasonography and duplex scanning, MRA carotid and vertebrobasilar circulation, MRI carotid and vertebrobascular circulation, carotid angiopathy for carotid stenosis, echocardiogram for cardiac mass or large impulsi, MRI brain and orbit, rule EEG to rule out occipital seizure disorder, and neurologist consultation. So either you will be able to think of this investigation and do it, or refer for neurology for further neuro-ophthalmology if available, or neurology for further evaluation, and cardiology to rule out whether he's seizure and MRI, and you have to consider this an urgent investigation, not to give a referral for 3 months or 6 months. You might dealing with life-threatening condition. In conclusion, remember that you will be the first line evaluating patient. And if you don't know, you will not recognize. This is the rule of ophthalmology. In conclusion, ophthalmologists should be able to diagnose and do the required emergency workup, treatment, and referral for neuro-ophthalmic emergency, meticulous evaluation, specific detailed medical history, avoid serious life or vision loss. I hope you get some benefit from this lecture for general ophthalmologist and for resident. And I'm thanking you very much for your attendance. Thank you. If there is any question.
Doctor, I have one question.
Yes.
For the malignant hypertension, you said we have to lower the blood pressure slowly to prevent something. What was it?
Yeah, okay. This is a very, very, very important because you know, I had couple or lot of patients actually during my practices. It's like 35 years or more in neuro-ophthalmology, where they go, for example, to a private clinic or a small مستوصف, and then they discover that yes, he have papilledema and he have high pressure, and for example the blood pressure is 200 over 110, and they go quickly decreasing the blood pressure in 1 hour or 2 hours to the normal. What happened with sudden decrease of the blood pressure is patient wake up after he improved his blood pressure with bilateral loss of vision because of ischemic optic neuropathy. It's very dangerous to decrease the blood pressure very quickly with patients with high blood pressure. It should be slowly decrease the blood pressure to avoid ischemic optic neuropathy. I see more than during my years, I saw a lot, maybe 10 or more or 15 patients who have sudden loss of both eye secondary to quick decrease of vision. أغلبهم كانوا في مستوصفات. You know, they know that they have high blood pressure, so they decrease the blood pressure within 1 or 2 hours. So sometimes they decrease the blood pressure within 24 hours, slowly decreasing the blood pressure. So this is a very, very important. And this is usually a message we share it with the medical, and we worse to tell them decrease the blood pressure slowly to avoid a loss of vision in both eye from ischemic optic neuropathy. Thank you.
Thank you so much, Doctor.
Any more question?
السلام عليكم.
عليكم السلام ورحمة الله.
الله يعطيك العافية دكتورة. حسن السيد, R3 from Riyadh Joint Program. Doctor, a question about the same topic, the blood pressure. Is there a certain protocol we need to follow to make sure that the BP doesn't go down too fast?
Protocol for the medical department?
Yes, for medication, how to decrease the blood pressure.
Yeah, usually they should usually they should know, you know, because when they evaluate why he have high blood pressure, they have to know what's the cause of high blood pressure. So usually in the hospital, the medical people should slowly tapering. I will not give them the medication. They know what to give him, but sometimes they just go quickly giving everything. So this is. I cannot put for them the medication. They know, but they should do it slowly according to the case. But they know that they should not do it. Give all the medication to decrease it quickly. Okay.
I see. Thank you, doctor.
Any more question? Okay. Thank you very much. Thank you for attendance. Thank you.